low back pain is super common. Most people worldwide at some point in their lives will have an episode of lower back pain. So when a patient comes to your office with lower back pain, what's your evaluation look like? What questions are you asking them? What are you looking for?
There's a lot of movement analysis that goes into physical therapy. So we're going to ask them how they move, how long it's been going on, what positions are painful, what positions ease some of that pain. And then from there, understanding the biomechanics of how people move, which is kind of our specialty. We will then break it into like, okay, is it a joint problem? Is it a muscle problem? Are there some disc issues or nerve issues that are going on? And kind of funnel from there the treatments that we're going to provide for them.
Yeah, I mean, I think it's really about location, like anything. Where is it? Is it going down the leg? Is it not going down the leg? And then some of the more serious questions, are there really any, for us, like red flag nerve type injury things that we need to make sure that maybe the patient is not appropriate for physical therapy. Maybe they need to go back, or, it's because sometimes they'll just come straight in and we're like, this is a little bit more serious. You need to be worked up, or like you're in the right spot. Let's just see what we can do.
You mentioned specifically about a structure that maybe some people are not aware of, the multifidus muscles. What are those muscles in the low back?
They're deep muscles in the low back. They help. So on the superficial level, you've got your extensor group that run the whole length of the spine. Multifidus is even deeper to that. It runs right next to the spine. It connects from the top down to the bottom of the side of the spine. It will help stabilize the spine. It's not like a big movement muscle, what we'd call like a primary mover. It's more of the stability and endurance muscle that helps to keep the body and the spinal column upright. We find a lot of times, kind of talking about today, that when there's pain or maybe some problem that's happened in your life, these muscles will atrophy, and that becomes a bigger problem, leading to continual pain in the body.
And you compared atrophy of the multifidus muscle to long-standing understanding of disinhibition in a knee.
Mm-hmm.
Can you tell us a little bit about that? What we see with knee arthritis and the quadriceps muscles, and then correlating it with what we see with the multifidus.
Yeah, for sure. So what we've noticed, I mean, we've seen this a lot with knee pain patients. When there's pain and swelling in any joint area, it inhibits the pain. Kind of take, for example, a surgeon going in and repairing an ACL. They will have swelling and pain prior to the surgery, and that leg, if you've ever had like a knee injury, like you don't feel like you can stand on it as strongly as you can the other side. You'll have this inhibition, this pain inhibition. And so we're seeing that. We've known that and treated in physical therapy. We've used electric stimulation. We've used other methods to help engage that quadricep muscle to allow more support for the knee. What we're doing now is applying that information and technology and putting that into the back. Mm-hmm. So we're getting and accessing this inhibited muscle of the multifidus and using electric stimulation to provide an answer, provide a stimulus to it to make it grow.
Mm-hmm. And so if a patient, say they come in, they've had lower back pain, in the case we presented this morning, it's been going on for 3 or 4 years, and it's starting to inhibit the quality of life, ability to work. It's a constant issue. Workup's done, and you identify, look, that there's some multifidus atrophy, and then you recommended the stimulation. How long do they do that for? What's the treatment regimen look like?
Yeah, for sure. We've seen it. It takes about 2 months. Just kind of imagine you going to the gym and needing to get stronger. The first 3 or 4 weeks, we call that a neuroprogramming of strength. You're going to connect your brain down to that muscle system in an improved way. Now, you're not making changes to the muscle in that time period, but you're improving the connection. Then after that, once that connection's really harnessed, you're then going to see hypertrophy, or is that technical term of muscle growth. The muscle belly will get bigger and you'll get stronger that way. So in our physical therapy program, we generally treat people for about 2 months of strengthening exercises using this technique, and are seeing some good results with it.
Good.
Yeah, I mean, the real tragedy when it comes to the way the body works, it's great. Like, as David spoke about with the knee, we have injury and swelling and it causes the muscle not to work. We get the same thing that happens at specific levels of the back. And there's been 2 or 3 research studies that have kind of verified that at the level where we have pain, we end up having atrophy of that muscle. So now we have a segment that moves too much, and we don't have the muscle to hold it in place, and so it moves too much and causes pain. So it's sort of this vicious cycle, and the whole goal with the neuromuscular stimulation is, can we strengthen that muscle back up and sort of override what the brain is telling it to do, so we can then reduce the pain.
Mm-hmm. What I really like about this is it's specific. And we've talked about in the past this idea of non-specific lower back pain. It's common. It's just sort of part of life. And yet, in this case, this is a common issue, and it's a specific diagnosis with a specific treatment algorithm and regimen. And I think that having the trained ability to make a diagnosis like this and recognize what's going on, and historically, multifidus atrophy, fatty infiltration of the muscle, and MRI findings have not been well recognized. People probably just didn't comment on it much. Many times the radiologist wouldn't even mention anything. And now I think it's more and more recognized, and I'm glad that you brought it up today, where you have a common symptom with a specific cause and a specific treatment algorithm that can really work for patients. So thank you.
You're welcome.
That's awesome.
Yeah.